Hello everybody, I am Dr. Richa Trivedi from zenonco.io and Love Heals Cancer. Today's session is about creating awareness around cancer. Let me first introduce you to zenonco.io and Love Heals Cancer. We guide cancer patients in their treatment journey. We aim to improve the quality of life of cancer patients through an integrative oncology approach that includes both complementary as well as medical treatments. We also provide end-to-end care to cancer patients and also help in their counseling sessions, medical cannabis, anti-cancer diet, Ayurveda, pain and palliative care. For today's session, we're joined by Dr. Navin Bhambani. Let me give you a brief introduction about Sir. He completed his MBBS from Seth GS Medical College and KEM Hospital, Mumbai. He completed his post-graduation from Tata Memorial Hospital. He did a 3-year rotational residency in oncosurgery, followed by a 1-year fellowship in thoracic surgery at Tata Memorial Hospital, Mumbai. He then completed various fellowships in thoracic and minimal access oncosurgery. Hello, sir. Thank you for taking time out and joining us for today's session.
Hi, Richa. Thank you for having me.
All right, sir. So, sir, would you like to say anything before we begin with the Q&A session?
I would say it's a good initiative. I think today cancer is one of, it's almost, I think it's dangerous to use the word pandemic in today's day and age, but it's literally kind of achieving pandemic proportions. It's no longer endemic only to the Western world or the urban population. It's across the board, and we are seeing numbers rising. So I think it's only fair to create a level of awareness. And I think not just awareness, I think we also need to create a level of confidence in people that cancer is not like a death penalty or a death sentence. So we definitely have room for treatment and a good focus on quality of life when we recover out of cancer.
Right. All right, sir. Then let's begin with the Q&A session, sir. So, like you've done your fellowship in minimal access oncosurgery, can you help us understand what are some common minimal access surgery areas? Like, where is it possible to do these surgeries?
Minimal access, I think, primarily would benefit cavity surgeries. And when we say cavity surgeries, we are implying the two big visceral cavities in the body. One is the chest, which holds the lungs and the heart and the food pipe, the esophagus. And the other big cavity is the abdomen, which is also colloquially labeled as the Pandora's box because it houses so much more than you can even imagine, right from the liver, the intestines to the urinary bladder, the kidneys. So access and treatment for surgical intervention into these cavities can be done instead of the traditional method of long, wide incision that tends to separate the tissues and give an access into these cavities to address them surgically. We now can do the same thing with a keyhole and putting in a magnifying lens attached to a camera and actually visualize the whole thing on high definition monitors and similarly conduct our surgery through keyholes, introducing 5 and 10 millimeter instruments, and complete the entire surgery under the guidance of this camera and observing it on the monitor, and then literally put a very minimal incision just to deliver the tumor or the specimen outside. So the common areas, like I mentioned, would be when we are dealing with surgery related to the lungs, lobectomy for lung cancer, esophagectomy for food pipe cancers, where we have to remove the entire length of the food pipe. We access the chest and the abdomen using minimal access. Again, another brilliant place where this comes to our rescue is in the deep pelvis. When we are doing surgery in any of the organs in the lowermost part of the abdomen, is where we have actually our urine bag sitting there. We have the prostate in males, you have the uterus in females, and you have the stool bag called the rectum. So any surgery related to these is significantly benefited by the magnification offered with minimal access surgery. Again, intestinal cancers, removing a segment of the intestine, what we call hemicolectomy, is also facilitated with minimal access surgery, and we are able to complete the entire procedure minimal access. Or if we are anyway going to make a small access incision to deliver the specimen out, we can sometimes do a little bit of cost cutting by doing the joining, the anastomosis extracorporally or just outside the body, and then with the use of staplers, and then re-deposit the organ back into the abdomen.
All right. So, sir, like you mentioned, the esophageal surgeries that is done. How often do patients require a feeding tube after undergoing an esophageal surgery?
Well, in my rule book, it's 100%. For the simple reason is, I think, safety first. I know there are people who would promote saying that we could avoid the feeding tube, but like we say, we always have a contingency plan in case of an emergency. When we are doing a esophagectomy or a food pipe surgery, we're actually removing the full length of the food pipe and we're replacing it by a newly stitched up stomach tube, a tube created by the body tissue from the stomach, which has been sewn with staplers or hand sewn, and then we join that with the leftover food pipe in the neck. So there is a lot of stitching involved or stapling involved. Any stitching or stapling is prone to possibility of a leakage. It's like a stitch going loose, and then food can leak out of it. In a scenario where something like that happens, a feeding tube serves as a safety valve, or even I would label it as a lifeline to salvage the patient's nutritional status while the patient heals. So, in principle, my opinion definitely is that all esophagectomies should get a feeding tube, and the options could be either having a nasojejunal tube, which we call a Frecka's tube. We put it through the nose and remove it pretty simply, versus a small surgical feeding jejunostomy, where a tube hangs out from the abdomen. The advantage of the one from the abdomen is it doesn't really hang out from the nose, so the patient feels a little more comfortable.
Okay. So, sir, like we've heard, a lot of cancers, like before the diagnosis, one needs to undergo the screening tests. So, how accurate are the results of these screening tests?
See, screening tests are the intention of screening tests, we should understand, is to save lives. And when I say save lives, I imply that if you suppose screened 1,000 people in the population, you've obviously spent, whether you look at it as financial resources or you look at it as medical resources, you've consumed resources to screen 1,000 people. At the end of screening 1,000 people, you should have discovered enough number of cancers at an early enough stage to be able to say that you actually saved lives, or the general population unscreened would have found this cancer at a later stage, where the patient would not have survived. So you have to have, when you do a head-on comparison between screened and unscreened population, your screened population should have some percentage benefit in terms of saving lives. Unfortunately, none of the major screening programs world over have shown a dramatic improvement in saving lives by screening, other than, I would say, the landmark thing which I think we can take credit for in India is pap smears. Pap smears done for screening of cervical cancer have really been life-saving in terms of picking up the disease early and instilling treatment at an early stage. Mammography for breast cancers is also another good example that was supported world over with good results. In India, I still believe that mammography is a very good screening modality and should be done in the high risk population. However, the Western world has probably reached a point where screening is helping them detect cancers at a very, very early stage. And those early stage cancers are so early that there is even a question mark arising on whether screen detected cancers would ever have caused symptoms or risk to life during the lifetime of the patient. So, are we over detecting and over treating cancers because breast cancers because of screening? So that is why mammography has fallen out of repute with the Western population. But I think with the level of literacy in our country, mammography still is a strong tool for screening. Screening modalities for other cancers have really not shown any dramatic benefit. Even studies that were done in very high risk Japanese populations, which because of their tobacco consumption habit, smoking, are very prone to lung cancer. But in spite of screening them, they really did not find it a value addition to include lung cancer screening as part of their national screening program. They now do it only on a paid basis, not paid by insurance or by the national healthcare system for high risk smokers as a screening CT scan. So there has been limited benefit in screening. I prefer recommending more easier and cost effective screening modalities like breast self examination. I think a monthly breast self examination should be conducted by all women over 35, and definitely those who have a family history of breast cancer or some high risk factor. Similarly, also a simple thing like fecal occult blood, blood found in a stool test, is a good screening modality for picking up colon cancers, and they're very cost effective. A simple stool test barely costs you 100 rupees.
Right. So, like you mentioned about breast cancer, how does the menstrual and reproductive history affect breast cancer risks, or does it are they not correlated to each other?
Oh, they are, on the contrary, very significantly. One of the risk factors for breast cancer is believed to be what we call the estrogen window. When I say estrogen window, it is the window period in a woman's life that she is exposed to high levels of estrogen, which happens starting menarche, when periods start, menstrual cycles start, up to menopause. And every cyclical period has a surge of estrogen that happens, which leads to eventually ovulation and subsequently a progesterone phase, which leads to the menstrual cycle. So the higher the exposure the to estrogen, that is early menarche, and unfortunately now we are also seeing, courtesy of probably our lifestyle issues, we are seeing girls in the second and third standard starting their periods, which is no, under even 10 years of age, and that means they've already been exposed to the estrogen window. And then they also seeing delayed menopause. Women menopause anywhere between 40 45 to 50 55. We are seeing a lot of women pushing their menopause age a little later. So the window widens basically. Again, there is a significant delay with, I would say, call it westernization, or even a number of women who are trying to strike a balance between the professional world as well as the personal world, and thereby delaying either marriage or planning a family and pregnancy. So, what pregnancy does, I mean, everybody only assumes it's like the philosophy of bringing a child into the world and probably then breastfeeding to feed the child. But there's a huge benefit that every episode of pregnancy and lactation does to the woman, the mother herself, because it actually gives you a 9 month break during pregnancy from estrogen, because there are no periods. So there is the estrogen is suppressed. It's a prolonged progesterone phase in a woman's life. Again, lactation, the longer we breastfeed, that suppresses periods from coming. Lactating women usually don't have menstrual cycles. So, and a lot of women now, in the necessity that they have to revert back to work, stop feeding at 3 or 6 months. Traditionally, women used to feed children beyond a year. So, somewhere that protection of a break from the exposure to estrogen is also lost. So these are a couple of lifestyle changes that have probably led to an increase in the incidence of breast cancer. Another contributing factor is industrialization. Now we don't just look at cow's milk, or we don't look at this thing. All industries are looking at increasing their volume of manufacturing. So how do you get a cow to generate more milk so that you have more volumes to sell? So there's a lot of hormonal exposure given to the cows, which gets excreted in the milk and is again consumed by us humans. Probably one of the contributing factors where children consume maximum milk. So children could be landing up with early menarche and periods, probably because of this unnecessary hormonal exposure.
Okay. So, and what are some other gynecological cancers that there are?
See, the commonest gynecological cancers, if I really speak in context to our country, is cervical cancer, which is the reason why I mentioned that pap smears were literally, I would call practice changing methods and life saving methods for our country. Uh, Basically, a gynecological cancer, if I was to just give you an umbrella covers cervical cancer, which is the cancer involving the mouth of the uterus, the womb in lay language, or uh, the uterine bag, the outlet is what is called the cervix, and the when the cervix has a growth over it, it's labeled as cervical cancer. The second commonest cancer related to gynecological cancers is endometrial cancer, which is involves the lining, the inner lining or the skin of the uterus inside, which actually changes periodically with the change in the hormones every 15 days. It's either thickens, and then that is the layer that actually comes out in bleeding. So it is affected by the hormonal changes that are generated by the ovaries. And then the third, of course, is the ovarian cancer. So these are the three commonest gynecological cancers. I think it is very important for us to understand that these three are uh, very high in our population because of poor hygiene. If you understand that there is a huge cultural taboo in our country about women discussing any genital issues, any issues related to their periods, it was even considered taboo or unholy for a woman to be bleeding during her periods. So, with all these cultural taboos, a lot of women tend to ignore symptoms related to their private parts, and they rarely would even discuss it out, feeling ashamed to go and approach a doctor. But bleeding out of a routine schedule, like intermenstrual bleeding, bleeding post-coital after an episode of intercourse, post-menopausal bleeding or spotting. These are typical signs that could be early hints of either cervical or endometrial cancer. Ovarian cancer usually presents with more of a fullness of the lower abdomen. You know, the tummy just seems to like have bloated up. You feel pregnant when you're not actually expecting a pregnancy. So that is another point that should not be ignored. People pass it off as just weight gain, but that's another aspect that should be kept in mind.
Okay, and so in what cases is an hysterectomy performed?
Usually, if I was to again categorize these three cancers, gynecological cancers, cervical cancer is largely a disease treated by radiation. So to put it in perspective, cancer treatment is got three main modalities: surgery, where you actually remove the culprit organ and maybe adjacent tissue what is required; radiation, where you radiate or you burn out the tissue without operating on it, or after surgery, where what you're aiming to do is actually sterilize or inactivate any microscopic cancer cells left over in the body after surgery, or inherently the entire tumor itself if it is a radiosensitive tumor. And third modality is chemotherapy, which is usually used in systemic cancers where the cancer involves more than just the local organ. It is spread to other organs also or other parts of the body. or is inherently a system involving like a blood cancer or a leukemia or something like that. So there we actually instill a drug into the body's patient system, either orally or by giving an intravenous injection. And that drug enters into the blood circulation and goes and kills the cancer cells wherever they are there in the body. Lastly, if I may add, nowadays we also have some focus on hormone therapy and immunotherapy, principle by which both of those work is also like chemotherapy only. Now, cervical cancers are primarily cancers that are radiosensitive. So, either very early stage cancers or mandatorily all advanced stage cancers, anything over stage 2 is treated only by radiotherapy, with or without adding chemotherapy if we feel there is an added benefit. There is no role of surgery for any cancer above stage 2 in cervical cancer. In early stage 1 cancers, there is an equal benefit with surgery as with radiation. That's why largely cervical cancers are radiation treated cancers or radiosensitive cancers. Vis-a-vis endometrial cancers, cancers of the uterine lining are primarily treated with surgery or with what we call a radical hysterectomy, where we remove the uterus, both the ovaries, the lymph nodes in the pelvic area that where this disease tends to spread first, and any other area of spread. Thirdly, ovarian cancers are a good example of a where combination therapy or combined modality therapy is of very significant importance, because they also melt to chemotherapy, but the benefit is very high in doing what we call a cytoreductive surgery. We reduce the volume of disease to be treated with chemotherapy by removing the uterus and the ovarian tumors, along with any other spread anywhere else in the abdomen. So surgery has a strong role to play in ovarian cancer, almost equal to that of chemotherapy.
Okay. So, sir, how are the chances of childbirth affected due to a hysterectomy?
Primarily, I think let's get our basics very clear. The for childbirth, the the egg is produced in the ovary, which then travels into the uterus. The uterine cavity sits in the endometrial area and is then fertilized by a sperm and forms a embryo, which embeds itself into the wall of the uterus, the lining of the uterus, and grows inside the uterus. So the uterus is the house for the child to grow. So not having a uterus primarily makes it uh, technically impossible for a woman to bear her own child. But in a scenario where you've had a hysterectomy, only removal of the uterus for either a very early cervical cancer, what we call a cyanocarcinoma in situ, like technically a stage 0 cervical cancer picked up on a pap smear, and the ovaries are intact. So the eggs can be produced by the woman, but there is no place for her to house the child that will be growing over a period of 9 months. So in principle, she can't bear her own child, but she can consider having her own child, that is having her own genes in by using her own ovum or egg from the ovary, which is removed by a process of ovum harvest, a component of in vitro fertilization or artificial fertilization, which is quite common now, and then fertilized extracorporally or in vitro using the husband's sperm. The embryo is formed in a laboratory, and then they have to apply for surrogacy. They have to request a woman who has a uterus to hold the child for 9 months, as they call a surrogate mother, and then hand over the baby back to the mother. So technically, the a simple answer to it be without a uterus you can't have a child. But if you are very insistent on having your own genetic material and have ovaries intact, there is a long drawn process where it can be made feasible.
All right. Okay. So, anything else you would want to say to our viewers before we conclude today's session?
I think these were good series of questions that I believe will sort a lot of FAQs in people's minds. And I think today we should respect the fact that a lot of media is available. Like I mentioned to you, a breast self-examination video is freely available on a Google search. I would encourage people to go through these material available and actually implement it on themselves. Do not get paranoid about the word cancer. There are so many people who get worried thinking that what if I have cancer, and in that tend to deny themselves treatment. That, it's like, I'd rather not know it than know it and treat it. So first thing is accept it, because the moment you pick up a cancer at an early stage, you have much better options available, wherein you can get treated well and live a reasonably good longevity as well as quality of life. If I give a simple example from this, there were traditionally breast cancers were treated by removing the breast in surgery. Today, breast conservation surgery, as we label it, or preserving the breast and only removing the tumor, has become a common practice, and I would safely say above 75% of my regular breast cancer treatment practice. So don't fear the worst. Instead, approach in time so that you are able to get good guidance and treatment. Also, stop fearing the word cancer. Cancer is no longer a death sentence. Today, I believe cancer has reached a point of becoming a chronic disease like diabetes, blood pressure, in many aspects like breast cancer, cervical cancer, where if picked up early and treated well, a normal life can be considered.
All right, sir. So thank you so much, sir. I think this was a very informative session. A lot of doubts must have been cleared today. And once again, it was a pleasure having you with us today. Thank you for taking time out and joining us today.
Thank you, Risha. All the best.
Thank you so much.